I am grateful to have this opportunity to quickly talk to you about pediatric procedural analgesia in emergency care. Let's see. So, yeah, as Andrew said, I'm a pediatrician. I'm working at Kailicha in Cape Town. I have no conflicts of interest in this talk, but I am a parent as well as a doctor. But all the views expressed are my own, and any equipment or photographs that I've used is just for illustration. It's not endorsed products. So the topic that I want to cover is procedural analgesia in emergency care. And to do that, I'm going to talk about infant and child pain perception, some of the physiological and biochemical effects of pain, and a practical approach as to how to manage procedural pain in the emergency department by implementing non-pharmacological and pharmacological methods. I'm going to talk about opiate analgesia. I'm not going to discuss ketamine sedation protocols. I think that's something that everybody's quite comfortable with, and there are very clear protocols available and guidance if anybody wants to know more about ketamine. So the outcome for you really, or my hope, is that by the end of this short talk, you might be motivated to advocate for child health and well-being in your hospital by championing prevention of pediatric procedural pain. And in doing that, you'll need to motivate for your wards and emergency departments to develop protocols to assist with prevention of pediatric procedural pain and to train your medical students and doctors accordingly. And I'm going to see if I can convince you to purchase or motivate to purchase two things for your department. And I'm wondering if at the beginning of this course, you might be able to guess what they are. Well, the first thing is bubbles. And I'm sure anybody who I've worked with and a lot of people working in pediatric emergency care will appreciate how useful bubbles can be in your pocket. The second thing for you to consider purchasing is this device. This is a mucosal atomization device. Okay, I've got 15 minutes and I don't want to talk too quickly, but we've got a bit to get through. So firstly, just to recap pain perception, and there are a few misunderstandings about pain perception in infants and particularly neonates. So we know that pain is perceived from about 20 weeks of gestation. And by 30 weeks in utero, CNS pain nerve tracts are completely myelinated. And we also know that neonates have exactly the same number or greater number of pain nerve endings in their skin as adults do. But what's different is the descending inhibitory pain pathways. And those are quite immature in neonates and only develop fully during infancy and preschool years. So in fact, neonates and infants may be more sensitive to pain than older children and adults. And of course, pain heightens anxiety and fear, which in turn will increase perception of pain. So briefly, I think many people are aware of the physiological and biochemical effects of pain. So we know that pain increases the heart rate, respiratory rate, blood pressure, intracranial pressure. We know that it causes muscle contraction and rigidity, nausea, vomiting, and emotional distress. If you read the scientific literature around pain in infants and children, you'll see that a lot of research studies measure catecholamine levels, salivary cortisol. There's also EEG and MRI findings. And then there have been quite a lot of literature published around the long-term effects, particularly neurodevelopmental impacts and specific pain-related behaviours that are carried from childhood through to adult life. And post-traumatic stress disorder is very well reported, particularly amongst children who have long-term health conditions and undergo repeated traumatic experience related to their hospital visits. We also know that pediatric procedural pain has an effect on the caregivers and how they respond to their child's pain and when they're likely to seek medical help. So I think one of the main sort of messages to try and portray here is that procedural pain is preventable. And it's actually quite easy to prevent. And I'm not sure why we don't try a bit harder. I've been talking about procedural pain management since about 2014 in my department, and I'm still struggling to get the message across to my team that this is really, really important. So I think the first thing that I'd like everyone to ask themselves, particularly in the emergency department, where yes, we see a lot of emergencies, but we also see a huge number of ambulatory well children as well, is the procedure really necessary? Is this painful procedure going to change the way that I manage my patient? And if it's not, then don't do it. Trust your clinical skills and findings and avoid the painful procedure altogether. But if it is necessary, then really, if possible, and I know it's difficult to find a helper, but assistance with the procedure, whichever procedure it is going to really help you and improve your chances of first-time success, which is obviously better for the child than having to have repeated unsuccessful attempts. Parents want to be involved in procedural, in the procedure. They want to help alleviate their child's pain and distress. And you can ask parents to help by, they can explain the procedure to the child, and they can employ some of the non-pharmacological techniques, such as talking, reassuring their children, playing with them, blowing bubbles, all of those things. The one thing parents should not be asked to do is they should not be asked to restrain their child while you do the procedure. Think about the environment where you're going to do these tests, and ideally you should have a dedicated treatment room or procedure room away from the child's bed space. That allows privacy, and if you can find some wall stickers or a mobile to create a calming environment, that's always beneficial. So we're going to talk about a combination of methods, pharmacological and non-pharmacological, because the combination of the two has been shown to work best in managing procedural pain. And the first thing to talk about is the non-pharmacological methods. And I think amongst my emergency medicine colleagues, I often come up with a bit of a barrier around the non-pharmacological methods, that some people see it as slightly unscientific and not necessary, but there is real science behind it. So we talked about briefly those descending inhibition pain pathways that develop during infancy and childhood. The non-pharmacological methods, that's where that works by increasing those descending inhibitory pathways so that the pain stimulus is reduced. So there's definite scientific evidence and a plausible scientific mechanism of action of all of these non-pharmacological methods that can be used for children of different ages. So for the neonates and infants, if you're really skilled, then keep the baby in mum's arms breastfeeding. Allow the mum to talk to the child, stroke the child, massage the child, and you do your bloods at the same time. For the preschool kids, we know blowing bubbles is great fun, singing songs, playing music, those things work really well too. But as children get older, you need to start involving them a little bit more in the decision-making around the procedure. So school-age children can be asked, for example, this hand, or they can have some involvement in the decision-making, give them some control, and then you need to give them a task to do. Counting backwards, blowing a really big bubble, reading a book out loud, playing video games, something which is actually giving them an action to do. And then for the adolescents, they absolutely need to be in control. And they'll often want to watch and talk through the procedure as it happens. And they really do, all children need privacy, but particularly the adolescents. So there are a few simple things that you might want to purchase for your department to help you with these non-pharmacological methods of procedural pain management. Just make sure it's all wiped clean and enjoy it. We're going to move on to the pharmacological methods, and for minor procedures, I think we're quite familiar, most people are quite familiar with sucrose and non-nutritive sucking for infants when placing IV lines and venipunctures. For older children over a month, there are local anaesthetic creams available. They're not cheap, but they are available. They do take about 60 minutes to work before the procedure. So you just need to take that into consideration if you're in the emergency department. And then for the older children, you've got the cold spray, which is obviously immediately effective, but you do need to demonstrate it before you spray it on the child, because otherwise you will frighten them as much as the needle without the spray. We place nasogastric tubes and urinary catheters in and out for sample, and there's local anaesthetic gels available that will anaesthetise that area for you to make that more comfortable as well. It only takes about 5 minutes to work. I just want to mention at this stage, as we're talking about bloods and venipunctures, radial artery stabs, radial arteries really should only be accessed for radial artery gas. When you need an arterial gas sample, that's a very, very sick child who potentially needs ventilating or is already on a ventilator. And there's not many other indications to access the radial artery, certainly not just to get blood samples that can be obtained from a venous puncture. And radial artery access is extremely painful, and we should try and avoid it if not necessary. And then the more major procedures that we do in the emergency department frequently, like wound suturing or drain insertion, fracture manipulation, burn scrubbing, we obviously need some stronger analgesia for these procedures. And for the small babies under 3 months, for those really quite major procedures, you might even want to consider a general anaesthetic, or you could use ketamine or an opiate analgesia. Things like lumbar punctures and pleural taps, you can use ketamine again or an opiate. For the older children, for an LP, you might actually be able to get away with some anxiolysis, small dose of midazolam and a local anaesthetic. I'm not really going to talk about simple analgesia, just to mention that oral analgesia, like paracetamol and ibuprofen, takes time to peak effect. So if your child is in pain, you need to use something that's going to work a bit quicker, but please remember to prescribe these for post-procedural pain. Briefly, I did want to touch on lat gel and wound management. I think if you're working in private, you will, in the emergency centre, you will certainly have access to topical lat gel, which is a brilliant combination of local anaesthetics and adrenaline. So it's a gel that can be applied that anaesthetises the area, and also secondary to the vasoconstriction kindly shows you exactly where the area is anaesthetised, because it will blanch the skin. The skin will be blanched. If you don't have access to that, you can speak to your pharmacy and they will might be able to make it for you. It's one of those things that there's recipes for pharmacists, so it's something you could maybe talk to them about. But what I really want to move on to talk to you about is opiate use in the emergency department. And I think we were all very sad to have to say goodbye to Valeron, everybody's friend. So we all got very used to using Tilidine or Valeron drops, an opiate analgesic, for when children came in with fractures or burns particularly, or when they needed burn scrubs or fracture manipulations and even wound suturing. Sadly, it's been discontinued in South Africa, and the standard treatment guidelines recommend the alternative to Valeron as either to be oral ketamine or oral morphine. But there's a few problems with oral ketamine and oral morphine in the emergency department, mostly that it takes about an hour for an effect. And often, yes, we're talking about procedural pain, but often those procedures are associated with a pain that's occurring at the time. So a child with a fracture or a burn needs analgesia at the time. We can't wait for an hour for these things to work. And we're all very used to using IV ketamine. I think those of us that can remember using oral ketamine before we used a lot of IV will remember that it is extremely frustrating, slow onset of yeah, it takes a long time to go in, and it takes a very long time to come out. Quite frustrating. And oral morphine as well takes some time to work, but also is often has to be ordered by case basis. It isn't always immediately available in departments. So what's the alternative? Well, this is the mucosal atomization device that I wanted to talk to you about. And I really do want to try and encourage you to think about using this in the emergency department. In the addition to managing procedural pain, this is also really very helpful for several other indications. So for example, you might want to give an opiate analgesia like fentanyl in a TET spell crisis, where you don't want to cause any additional pain to the child. You can give midazolam this way for seizure management, and you can give ketamine as well for anxiolysis, analgesia, or sedation through the mucosal atomizer device. So multi-purpose and worth the money, I think. Fentanyl is always available emergency drug and quite safe for children over 12 months when given intranasally. It's only contraindicated if the GCS is reduced or the child has got a blocked or bleeding nose. The dose is somewhere between 1 and 2 mics per kilo, and the usual concentration, but you must check what you have, but the usual concentration is 100 mics per 2 mils. So you work out the math for the dose, and the side effects really is the same as opiates, but it's actually very rarely reported with the correct dose and application. If respiratory depression, which is what everybody is anxious about, does occur, then conveniently naloxone can also be given intranasally. So for fentanyl administration via a mucosal atomizer device, you would need to calculate and draw up the correct volume of the drug in a Lurlock syringe, attach the mucosal atomizer device onto the syringe, position the child at about 45 degrees with the head turned to one side, gently insert the device, and then firmly press the plunger. If the dose exceeds 0.3 mils, then you just divide the dose for each side to maximize the absorption. And you wait about 10 to 15 minutes. If you don't think that it's given adequate analgesia, then you can repeat that dose. Usually it's very effective, and it's effective within sort of 3 to 4 minutes. It peaks between 10 minutes and half an hour and lasts for an hour. And so that was just an example of a calculation. Of course, you still need the bubbles. So fentanyl is an analgesic, and you still need the non-pharmacological methods as well to help with anxiety and to help with making the procedure more comfortable for the child. So in summary, I think what I'm trying to say is that procedural pain is a common negative experience for children and their caregivers when accessing emergency child health services, and it is preventable. We can use non-pharmacological and pharmacological methods in combination for best effect. Minor procedures like blood tests and IV lines do hurt, and repeated episodes have long-term effects for the child and their caregivers. Ketamine is great, but there are other options available for analgesia. And the intranasal route for opiate administration is pain-free, is safe, easy, and it's quickly effective. For anybody who wants to do any further reading, the SASA guidelines for 2021 are available, and a good read if you wanted to read more about analgesia and also sedation. Thank you very much.